Now it's a big pleasure to announce my friend and colleague from Austria, Franz from Salzburg, to give his lecture about open abdomen or what to do. So, Franz, it's your stage.
Mr. Chairman, dear colleagues, dear friends, as probably some of you might know, open abdomen is not the easiest thing to deal with in surgery, and even it's not an easy thing to talk about that. So it was a hard job for me and to prepare for that talk, and I hope I will finish on time because there's a lot of things to be that need to be talked. How can we go on? Yeah, okay. First of all, here are my disclosures. There's no conflict of interest. And as you see, I quite always try to look hard to sit on the right side of the limb. First of all, I want to thank Victor and Mirka for this fantastic organization of this meeting. And it's really an honor for me to take part at this meeting with the hernia family here in Bucharest. In surgery, we have to have a plan before we do something. And in this talk, I want to lead you to some aspects of this topic. I want to start with definition, then reasons and indication for an open abdomen treatment, then management of the disease or the disaster in some cases, and finally, leading to some kind of expectations or goal of treatment. First of all, it's necessary to restrain the surgeon's impatience in many cases. And as the soccer players of you probably know, scoring a goal doesn't always mean to win the match, as this means if you have success in treating a patient with open abdomen, the next day can be quite different. Let's talk about definition and classification. Open abdomen is, in most of the cases, an intended surgical option for treating critical ill patients, to control sepsis, to avoid abdominal compartment syndromes after fascial closure for various reasons. On the other hand, we have burst abdomen, which is an unintended acute wound failure, meaning it's a descent of the level of the fascia or skin. That means open abdomen is not a complication of surgery in most of the cases, whereas burst abdomen definitely is a complication. To sum up, these problems they remain the same. How can we get it closed? Or what is the rate of mortality, which is quite high, up to 30% in these patients? If you talk about a disease, we know it's mandatory nowadays to classify these patients. The one patient, it differs in many aspects to the other patients. And talking about open abdomen treatment, the Berg classification is in the meanwhile worldwide accepted. We have 4 stages of the disease. That means this refers to the grade of adherence between bowel and abdominal wall. And we have several grades, A to C. This refers to the grade of contamination of the abdomen leading up to enteric fistula. Indications for an open abdomen are mainly abdominal traumas or non-trauma patients. Abdominal traumas require, in many cases, some techniques of packing, elevated blood pressure, elevated bladder pressure when you close the abdomen, or you might be confronted with patients with severe abdominal wall tissue loss. Or you might have an abdominal trauma patient which develops in its further course some kind of abdominal compartment syndrome. Whereas non-trauma patients are mainly patients with abdominal compartment syndromes after failed medical treatment, vascular emergencies, peritonitis patients, and patients with pancreatitis. All of these indications are mostly unplanned, unintended, always or almost always at the wrong time, often at the wrong place, and maybe not treated by the most experienced surgeon at the first stage. So it's worth to think about some kind of, let me call it semi-elective indication for an open abdomen treatment, a concept which we have followed in my institution many years before. If we are presented with an emergency case like perforated diverticulitis, anastomotic dehiscence with peritonitis or burst abdomen. Most of you, of course me too, intend to solve the problem in a single stage curative option. That means laparotomy, resection and anastomosis, lavage, drainage, and closure of the abdomen. So this is the ideal plan. But as you know from space traveling, Houston can have a problem. And even surgeons can have a problem on night, on duty, on the weekend, if an unexperienced team is on duty, or if you are confronted with non-adequate resources, for example, even for financial reasons. So in this case, it might be worth to think about some kind of institutional therapeutic guidelines. That means, at the end of the day, don't take the risk. Resect what needs to be resected, avoid stoma or anastomosis, lavage as much as possible, and plan the patient for negative pressure therapy. With a plan behind that, that means planned reintervention when all resources are present as needed and the patient, in most of the cases, is in a better condition. Or you refer the patient to another institution where the patient is, in this case, at the right place, in the right hands. Just a word about intra-abdominal hypertension. You know that this goes from an intra-abdominal pressure from 12 millimeters of mercury up to more than 25 millimeters of mercury, whereas talking about abdominal compartment syndrome means that you have an intra-abdominal pressure of more than 20 millimeters of mercury plus organ failure, such as renal or pulmonary complications. In this case, the alarm bells have to ring. Management of open abdomen is mainly due to the possibilities you have to treat this patient on an ICU. This means these patients definitely need multidisciplinary approach, IAP measurement, optimization on many fields of intensive care treatment. You have to avoid hypothermia, you have to create your fluid management in a careful manner, and if you have coagulopathy, it's mandatory to downregulate your negative therapy. Nowadays, negative pressure therapy is the most important part of treating these patients by a temporary abdominal closure. Other options, not using negative pressure therapy, like the old Bogota pack, which some of you might know, results in lower rates of abdominal closure and definitely in higher rates of intra-atmospheric fistula. Whereas a combination of negative pressure therapy, and continuous lavage, like the vacuum still system, or a combination with Botox infiltration or the use of the Fasciotense device is definitely unknown. We have no good data about these options of treatment. And finally, you might think about cutaneous closure by skin flaps. Well, this is an option, but it's definitely not the best option. If you have to surgically re-explore this patient before definitive closure, it's necessary to plan this precisely. That means that you have to change negative pressure therapy at least at 24 or 48, up to 48 hours after initial installation. And you have to immediately re-explore these patients if they become hemodynamic unstable. Open abdomen should maintain when the patient is on a continuous resuscitation if you find ischemic intestine or ongoing abdominal contamination. Open abdomen treatment with negative pressure therapy, what can we expect by using this concept? There's a fine publication by Gasser from the University Hospital of Innsbruck. It shows that we are confronted with a high risk of mortality, up to 21%. We have long hospital stays, long ICU stays, negative pressure therapy procedures up to more than 30, median 3, and a fascial closure rate of up to 95%. This is mainly due to the use of negative pressure therapy and a stepwise approach to the fascial closure. At that point, to say it clear, please don't believe the myth of biologicals. There are some publications right now coming up which show that this is not a good concept in these patients. There's one study, a randomized trial by Michael Rosen, who showed very clearly that synthetics for repair of contaminated ventral hernias are definitely superior to any kind of biologicals in these critically ill patients. Another important question to be answered: what are potential factors that influence the rate of fascial closure in open abdomen treatment? And there's a good study by Wilmy and Fortelny, which has been published 2 years ago with data from the EuroHIS registry. They examined 630 patients and found out in multivariate analysis that positive factors are the use of negative pressure therapy and the use of dynamic fascial closure, whereas abdominal contamination and the number of interventions before you close the abdomen are a negative predictors for the success, that means for fascial closure. Open abdomen treatments definitely needs an aggressive source control. You have to focus on the focus of the problem. Decision for open abdomen is a good one if you are in doubt, but this means you have to decide as early as possible. And negative pressure therapy is a must in treating these patients, whereas the dynamic fascial closure is a must too. How can we do that? There are some systems on the market, like the Abra device or mesh-related traction devices using IPOM meshes. There's, to my knowledge, one study from the Netherlands, from Portmont, who compared these devices, and they found out that the Abra device has a high rate of fascial closure with a low rate of intra-atmospheric fistula, but the mesh-related traction by an IPOM mesh leads to lower rates of fascial closure and a higher rates of intra-atmospheric fistula. Intracutaneous or intra-atmospheric fistulas, this fact is another dimension of the disaster of an open abdomen treatment. Here you see a case we had to treat over 9 months in the last month, sorry. And please let me say some words about intra-atmospheric fistula and their treatment. It's important to state that you can, or even you should, wait for spontaneous closure of these fistula in cases of low output fistula, of course. This time can be or should be needed for patient optimization, wound management, and stoma management or wound care. And to say it clear, please wait with the timing of intra-atmospheric fistula closure. There are 2 studies in the literature who give some kind of answer to this question. If you decide to close these fistula early, you have to be aware of a high rate of mortality up to 100% and a very high rate of recurrence of this problem. Whereas if you decide to wait for up to 12 months, you lower these rates almost dramatically. This is a case which probably, or this is a case of a former abdomen therapy, which led to a hernia. And the hernia is what we are dealing with every day. This is an incisional hernia, in this case, covered with a skin flap. 2 years after the open abdomen treatment in a young lady, 34 years old. And the whole disaster started with a bypass operation, with a simple cholecystectomy, and patient developed an incisional hernia. Was treated via an emilus technique and small bowel perforation. Well, this can happen, peritonitis can happen, but the management afterwards was not the best one. So after some, I think it was more than 10 days, patient was transferred to our department with an open abdomen. Needed multiple, I don't know how much, multiple revisions, segmental resection of small bowel, abdominal negative pressure therapy, dynamic fascial closure, and finally, we decided to perform a split skin graft closure in this case, because we couldn't close after this long period of time. Patient came to the hernia clinic and we decided to perform a Botox infiltration, laparotomy, adhesiolisis, retrorectus sublay with fascial instruction. That was our first case. No component separation in this case of a very wide defect. And finally, we decided to perform an appendectomy because it looks like a little bit strange, maybe after peritonitis, but let's take it out. Send it to the pathologists. Oh my God, things go on, neuroendocrine tumor, PT3. But the patient didn't need any kind of further surgery because of his low grade of proliferation index. What I need to say very clearly is that we need data, and probably it's a good idea for everybody of us to bring in his data into the EuroHIS registry with the open abdomen chapter to create new evidence on this really dramatic disease. Take-home message, this should be that open abdomen treatment is mostly not a complication but a complex disease. It needs multidisciplinary management in dedicated centers, a stepwise approach with intra-abdominal negative pressure therapy, dynamic fascial closure, and synthetic mesh in some of the cases, not in all, definitely not in all. Results of open abdomen treatment become in earlier closure rates better. We should try everything to avoid intra-atmospheric fistula. And in the case of a presence of intra-atmospheric fistula, delayed surgical reintervention to cure this problem up to 1 year is recommendable. And definitely biological meshes are not worth the money to use for. Let me conclude by inviting you to come to the Salzburg Hernia Days in March next year with a very interesting program, artificial intelligence, virtual reality in hernia surgery. What's that? Fact or fiction? And day case surgery, which is not normal in the country I come from, in Austria, maybe in your country. Thank you very much for your attention.